our workshops. And my name is Isabel Lucia. I'm from the University of Victoria in South Africa. So my passion is critical care. I've been a critical care lecturer for the past 28 years. So that is my ultimate passion. And also I do also teach in undergraduate programs. I do all the medical surgical programs with the students as well. But my other big passion is clinical nursing. I think because I first worked for 12 years in an ICU before, and then I started as a clinical nurse educator, and then later I went to the university. But what is very nice about our university is that we still have dual roles, so we do the theoretical component and then we also do the clinical component. So that's why I think I've got such passion for the clinical nurses, for nurses working in the critical care, but also in the medical surgical fields. And I was talking to some of you during our break, is that a lot of this training that I do, we also involve midwives, we involve the units or nurses from medical surgical units, operating theatre, because in essence it's about the principles. So I think my session today is much more from a practical point of view. I always say you have to walk the walk before you can talk the talk. So we always want to tell nurses what to do, and you have to empower yourself, but I think it starts with us. So, lead by example, as Kathleen said. So, and I've also seen in a lot of the units where I work that something very small can make a big difference. And just to link to her talk about, the workplace culture. In our country, we've got 11 official languages, so you can imagine how many different cultures we have. So on one day, if we are, let's say, 8 nurses on duty, we can have 8 different cultures. So we also had to decide, okay, we all got our own culture, but when we come to work, we also have a workplace culture, and how to create that workplace culture where everybody feels respected and where you can bring something to the table. And at the end, we are all there for the patient. So sometimes, really just by changing one small thing. So just to give you an example, we had, I was actually called to one of the units in one of our big academic hospitals, and they really had a lot of, conflict, and there was a lot of, really not a very nice workplace culture there. So then again, and that's just to also link to what Kathleen said, is that we had this open discussions, we talk, and we say, okay, what are we going to do? Because we just focus on one thing, that was greeting. Because in some of our cultures, if the person is older or it's your senior, you have to greet them first. In other cultures, if you don't greet, they don't greet you. It was a whole thing about trying to get those 11 cultures to come to, okay, what are we going to do in this workplace culture? And the only thing we changed in that unit, and that came from them, and I think that is also what I want to stress again today, is always about collaboration. It's about, when we do workshops like this, or we have those discussions, if we just go around the table, we just ask each of you how many years of ICU experience you have, and we write it on the board and we add it up. I'm sure we'll have 100 plus years, am I right? Because myself, I've got 35 years. Kathleen? 44. It's already, and if we add around the table, can you see? And that's usually how I start to say, if we make a plan with all this collective wisdom, nobody can make a plan like we're going to make today yet, if we're going to change something. So that is also, again, coming to that thing of respecting people, to say, even if you've got 1 year experience, you've got something to give. And if we add that up, so the only thing we did that day is we spoke about what is going to be our workplace culture relating to greeting. And at the end, all of them decided, okay, irrespective of my culture, what we're going to do when we're here at work, we're going to greet first. And the only thing we changed in that unit, we implemented, and you hear what I'm saying, we. I didn't say this is what they have to do. We just implemented. When it's visiting time for 10 minutes, we had a meet and greet session. So whoever nursed that patient that day introduced themselves, they greeted the family, and they just gave them a little bit of overview. This is what happened. bring the doctor around, they're going to do this investigations, just something small. And within a week, you will not believe how that whole unit changed. Because the work environment changed to positive, because now they will say, oh, Sister Susie, how are you today? Because yesterday you greeted them. The day after that, it was just a change in that unit. And what we did, we just looked at what other things changed. So teamwork changed. The professionalism changed. Even the feedback from the patient surveys. You couldn't believe 6 weeks later, this was the same unit. And the only thing we did was we changed one small thing. So I think that's just a message linking to what Kathleen has said and what I'm going to focus on today is that just, change, you start with something small. And it's really like when you throw a stone into the water, that ripple effect. Other things started changing. We didn't focus on teamwork, we didn't focus on professionalism. Even, on the orders of their drug books, that improved because all of a sudden they started working as a team. To say, oh, no, I don't have the drug cover today, it's not my problem. I don't carry the key or whatever your responsibilities were. So a lot of those things have changed. So coming back to what I'm doing today, so I'm going to look at how are we going to recognize the deteriorating patient. I think also linked to what we discussed this morning, and again post-COVID, what we see with our nurses we've got in South Africa, a similar challenge. A lot of our senior nurses after COVID retired, and some just said they want to work somewhere else. And obviously the new generation, for me, just to teach the students to touch your patients, to talk to them, to look at them, because in that time of COVID, nobody was so scared. So sort of just to change that back again is quite a challenge, but we can change. So what we're going to do today is to look at how are we going, so again, all of us are here, so we want to learn, we're learning from each other, that is excellent. But also taking this back to your unit, taking this back, because it starts with the patient, it starts with your colleagues, your students, whoever's working with you. So what I like to do is I like to start on the other side, to say, if the patient is not hemodynamically stable, what will happen to the patient? What is going to happen? Because if we are aware of the outcome or the impact of that, and we work towards this side to say, okay, but if this is what's going to happen, how are we going to detect that early so that we pick up the deterioration? And we do a lot of discussions, so if we have patients that there was maybe a near miss or there was a deterioration, and we go back, we try to see, but why was it missed? Why didn't we pick it up? And those are the small things that can really make a big change. So I'm also very old school. I have a PowerPoint, I'll go through it a little bit later, but I like to write and to talk. I'm also very interactive. So I always feel if we have, we're just all on the same page if it comes to hemodynamic monitoring. And I do a lot of, with the students. And I tell them, okay, today we're going to talk about vital data, then I get that rolling of the eyes, because I think of, vital data. And I always ask them, why do we call it vital? Let us start there. What does vital mean? And then they realize, okay, that's important, that means important, and they'll give you all those words. And I said, yes. But what do we see in practice? Well, in our country, definitely, in all the areas in South Africa where I go. Who does the vital data? The most junior nurse, the students.
Ours are the unlicensed personnel.
All the yeah. So you see, for me, that's where we have to change practice. It's not as that because it's either the first or the second years, or the junior or the nursing assistant. So to just record it is one thing, but it's all about the interpretation thereof, because that's where that it comes in that we miss those signs, of deterioration. Because to just report it, they don't have the knowledge and skills at that stage. They can maybe do it, they record it, but they can't really interpret it and link it to the patient's history. And that's why I feel that we have to change that practice, or at least let them work with a clinical nurse specialist or something like that. because they don't really, they see it there, but they don't pick up the signs. But what we're going to focus on, and that's why I say it's much more a practical session for me today, is that if we look at hemodynamic stability, it's all about the patient's vital data, it's about shock, it's about hypoxia. And every time you come back to a patient that is deteriorating, it comes back to two things. Either an oxygenation problem or it's a hemodynamic problem. So they all go into shock. And that's what we need to pick up. So I always tell the students, remember, there's 3 important things that your blood pressure regulates. And I'm so sad there's not a purple pen. I'm not having enough purple. And there's 4 components that we need to have optimal blood pressure. So if we look at the blood pressure, it regulates the cerebral perfusion pressure. I'm going to look at each of them. It regulates the renal perfusion pressure and the peripheral perfusion pressure. And on the other side, so this is what we're going to focus first on, because that is sort of, if your blood pressure is not optimal or you deteriorate hemodynamically, you go into shock, what is going to happen? What are we going to see when we assess the patient? And irrespective of what type of shock the patient has, they will deteriorate to this side. And then on the other side, we're just going to also touch on that, is that you need 4 things. So we need optimal volume, circulatory volume. That is also a bit price, I think it will be the green one. Then we need optimal cardiac function. We need a certain systemic vascular resistance, and then you need a heart rate that is more than 50 but less than 100 per minute. And this is the only one we're not really going to touch that much today, because this is more focused on your ECGs. But this is what we need to have a stable hemodynamic patient. So we need the optimal circulatory volume. If not, those will be the patients ultimately that will go into hypovolemic shock. These will be our patient that goes into cardiogenic shock, and then ultimately this patients will be our group that mostly go into septic shock. Right. And then obviously, so in adults mostly we aim for a systolic blood pressure of more than 100 millimeters of mercury at least, to ensure that there's optimal cerebral, renal, and peripheral perfusion pressure. So we want enough pressure to give off oxygen to the brain and to all the other tissues and systems in the body. So the moment there's a deterioration in the patient, we're going to see it on this side. And this is what we're going to see when we do the patient's assessment. So, and this is so important. So I always tell the patient, so where do we always start? We always teach the students, that's why I say we have to practice what we preach. We start with the history. So I always ask them, so what is history? Then I've got long stories. I said, there's the golden thread. It is about the story. It's his story. So it's the patient's story. So we need to know what happened. What did the patient complain of when he came in? Because already, this is going to put us, already giving us some idea what do we expect. So if this patient comes in, for instance, with a history of diarrhea and vomiting, already we're thinking fluid and electrolytes. You know, they're coming with a history of some, let's say, chest pain, that type of thing. We're already thinking something cardiogenic or cardio-related. And mostly, with septic shock, we're thinking of things like infection, trauma, surgery, that type of thing. So that is important. But what we want to focus on is on this deterioration, because irrespective what the cause is that side, what's going to happen, all of the patients have the same thing in common. They're going to present with decreased cardiac output. And then I always ask the students, so what is the latest sign of shock? Or normally, when do we act? So when they call us to the ward, when a patient comes in, and they are sometimes, mostly they're already actually in shock. They're already in a cardiogenic or a hypovolemic shock. But what is so important is if we look at hypotension, we all know hypotension is the latest sign of shock. That's a sad thing for the patient. Because that means by that time, all the compensatory mechanisms is already exhausted. It is utilized, and then there's actually nothing left for this patient to fall back on. And that is sadly sometimes when they only call us, is when they see this severe deterioration. And then it's actually already too late for the patient because all of these complications will already be evident in some or other way. And that is what we're going to focus on, to see what is those signs and symptoms that we have to look at. And we'll summarize that at the end. But first of all, I just want us to go through that. So what will happen to this patient? Now again, irrespective of what type of shock, the underlying very important thing here is just for us to remember, if we look at hemoglobin, each hemoglobin carries 4 oxygens. Each hemoglobin carries 4 oxygens. And we all know we need a certain level of hemoglobin. So I don't know all the levels in your countries, but with us we usually say we need at least 12 to 14 grams per deciliter. That is sort of our guidelines. I don't know if it's the same here. So we want at least a hemoglobin of 12 to 14 grams per deciliter. Now the other thing that's also for us a challenge in South Africa or in the whole of Africa is that there's a severe scarcity of blood. So now, if you're in the government hospital, you might get blood if your HB is 8 or less. If it's a private hospital, you might get blood around HB of 10. So now it's sort of, people think, oh, the HB is 10, they're happy. Because they don't need, there's not a need for blood. But we're not talking about transfusion HB, we're talking physiological. Physiologically, we need 12 to 14 grams per deciliter of hemoglobin to carry these oxygens to the tissues, the muscles, and the cells. And that is the other thing. So also that's why we need to assess the patient's PO2 level. So mostly there we say 70 to 100 millimeters of mercury. That's what we want. Then we know there's enough oxygen to bind to hemoglobin. That's why we need at least 12 to 14 grams. And then we know when this oxygen comes to the tissues, the muscles, and the cells, it needs to be given off. So for that, we need peripheral perfusion pressure. And what regulates the peripheral perfusion pressure, as we saw here, is the blood pressure. So those are the 3 things we need. So that's why we want this, at least a systolic blood pressure of 100 milliliters of mercury in all our adult patients. We need to have at least the HB of 12 to 14 grams per deciliter, and we need a PO2 of 70 to 100. Then we actually know we've got those components already. That's where we need to start. Irrespective of the patient's history, we must make sure, is there enough oxygen to be given off? Is there enough hemoglobin for oxygen to bind to? And is there enough pressure to give off that oxygen? And those 3, and sometimes sadly, some of our patients can have, let's say the patient is bleeding. Obviously the pressures will drop and the hemoglobin will drop. So they can even have more than one contributing factor. Those are the small things that we have to assess, that we have to pick up. And that is actually what everything is about. Because now what's going to happen, if we now look at the different systems, we're going to see basically what happens. So if the blood pressure, if there's a decrease in the blood pressure, meaning it's less than 100 milliliters of mercury, then there's going to be a decrease in the peripheral perfusion, pressure. There's going to be a decrease in the cerebral perfusion pressure, and there's going to be a decrease in the renal perfusion pressure. And now we're going to see how that will influence all the different body systems. So that was just sort of to put us all on the same baseline. So what we will see here, so first of all, I'm just showing you how beautiful our country is that they call us the Purple City. Now I've also got the there it is. So that's just a picture of our university building, just from the photo. So that is our campus there, that side. They call us the Purple City. So in October, this is what we look like. All the jacarandas are blooming. So the students have this belief that if you walk under the tree and one of those blossoms fall on your head, you're going to pass your exam. So sometimes they're shaking the trees. But anyway, that's just how we look there. Yeah, so this is the wrong side. So this is basically just coming back to this little picture that we see. So if we come back to this, that forms the baseline. So when we look at hemodynamic monitoring, then we've got the volume, which is represented by the preload. We all know preload. So this will basically be any volume-related issue. So if there's not enough volume in circulation, it means that there's going to be less preload, and we all know volume equals pressure. So that's also already, can you see from the history, do we identify, and I've just tried to give a few examples. So if there's any history of some circulatory volume loss, so maybe the patient bled, maybe from the history we know it's the patient just delivered the baby, so there might be bleeding, patient had surgery, or sometimes there might be wound drainage if you think of your burns patients. Any patient where there's an increase in the capillary membrane permeability, so we see that third spacing, where you see the fluids in the third space, so intravascular they're going to be dry. Even patients with a decreased albumin, like your patient that's malnourished, or if the albumin is low, also get third spacing or leakage of fluid. So it means that the circulatory volume will decrease, and therefore your cardiac output will decrease, and the patient will be hypotensive. But already from the history, can you see we must red flag certain things. So if there's a history of bleeding or diarrhea and vomiting or anything that we can pick up that can already relate to preload, we know that already there's going to be challenges with circulatory volume, which means there will be challenges with cardiac output. Or as we said, there can be a challenge in terms of contractility. So that's more where we're going to look at anything that can alter the contractility of the heart muscle. So again, from the history, is there any history of, so hypertension and hypoxia and anemia goes hand in hand, because as we said, if there's not enough pressure to give off oxygen to the heart muscle, what's going to happen is going to be myocardial ischemia. And also now, if you think of your compensatory mechanisms, so when the patient starts deteriorating, what's going to happen? The body will release adrenaline and noradrenaline. So that's normally one of the first things that we're going to see, is that the patient's heart rate will start to increase because of this release of adrenaline and noradrenaline. Now I've lost my pen. So already when there's any compensation, there's going to be the release of adrenaline and noradrenaline. And that's usually where we start seeing, so we know adrenaline works on beta 1, beta 2, and alpha receptors. So as always teach students, you've got one heart, you've got two lungs, and then your peripheral. So there you get vasoconstriction, trying then to increase the pressure. Then beta 2 will improve oxygenation, and beta 1 will increase the heart rate. So already that's usually our first sign that we start seeing, is that this patient might have or starting to present with a tachycardia. And that's the thing, we must always ask ourselves, why is there tachycardia? Even at that stage, if there's still a normal blood pressure, because initially the patient will be able to compensate. So because of this release of adrenaline, because of the vasoconstriction, then you can still maybe manage the systolic pressure of 100, 105. But there's two very important things already here that we're going to observe. So the one thing is there might be a tachycardia, so the heart rate will increase, start to increase. And the second thing that we're going to see is that the blood pressure is going to be, let's say, 110 over 85. But can you see what are we seeing there? That the diastolic pressure is high in relation to the systolic pressure. And that is because of this alpha receptors, because of this vasoconstriction, the body is able to increase the blood pressure. But this already must raise alarm, because this is already showing us this patient is compensating for something. But then we look and say, this is the blood pressure still fine, it's 110. But we have to then scrutinize that blood pressure. If the diastolic pressure is high in relation, it's already showing us compensation. Even if the heart rate is maybe 107, 105, it's slightly elevated, but it's still elevated, so we have to ask ourselves why. Because something is going on underlying. And now what we will see is that so let's say, contractility, yes, your big group of patients here can be your typical cardiogenic patient, where obviously going to cardiogenic shock, but they're sort of in a separate category. The other things that we see in any other patient that is hypotensive is there will be, obviously if they're hypotensive, it can also influence the contractility. Because if the cardiac muscle is ischemic, you get that negative inotropic effect. So there's less stronger contraction, therefore the cardiac output decrease. And the same if there's hypoxia, also then there's not enough oxygen to be given off. And remember now what's happening underlying, because of this release of adrenaline and noradrenaline, there's also specifically adrenaline, it's going to work on beta 1, so the patient's heart rate is increased. So what happens if there's an increase in the heart rate? There's going to be increase in the oxygen, the myocardial oxygen demand, and then that imbalance between demand and supply becomes more significant. And that has a negative inotropic effect on the heart muscle. And the same, so those three, so whether there's not enough pressure to give off oxygen, not enough oxygen to be given off, or not enough hemoglobin for oxygen to bind to, what happens on tissue level? There's less available oxygen. And then that imbalance between demand and supply is more significant. And myocardial ischemia then leads to negative inotropic effects, which means that there's less stronger contraction, less cardiac output, less blood pressure. So it's really a vicious circle. And also another very big issue here is that these patients, or any patient that starts to deteriorate, whether it's due to the level of oxygen available or the pressure to give off oxygen, what's going to happen on tissue level? There's that imbalance between oxygen demand and oxygen supply. So those patients then develop, or they go into this anaerobic state of metabolism. So because of the lack of oxygen, and that anaerobic metabolism leads to metabolic acidosis, or when we do the arterial blood test, we always look at the lactate, because the lactate will be high. So lactate tells us that there's poor tissue perfusion. It's either due to hypertension or hypoxia or both. But what does that lactate tell us? It tells us that there's impaired tissue perfusion, and if this patient now develops metabolic acidosis, then there's going to be hydrogen ions in circulation. And again, hydrogen ions has two negative impacts. It also decreases the contractility, so it also enhances this negative inotropic effects. And also because of it's acidic in nature, it also causes myocardial irritability. And the patient then starts getting dysrhythmias, VEs, any type of dysrhythmia, which further decreases the cardiac output. And then also to look at our electrolytes. As we said, if there's any history of fluid losses, diarrhea, vomiting, burns, nasogastric drainages, anything where the patient can lose these important specific potassium, magnesium, and phosphates, that also has a negative impact on contractility. There's also a higher risk for dysrhythmias, and you can see the cardiac output goes lower and lower. So can you see it's a vicious circle? It's not just we do the vital data, we look at the blood pressure. We really have to break it down, to scrutinize it. Does it link to the history? So that can be, or it can be a combination as well. But then obviously, can you see already, even if this patient is primarily, has got primarily preload problem, can you see now secondary, there's also going to be negative impact on contractility because of not cardiogenic shock, but because of a negative inotropic effects, because of this ischemia of the heart muscle. And this MDF, the myocardial depressant factor, is also very prominent in any patient where there's gastric ischemia, if they have ischemia of the pancreas. then there you get the release of this MDF, or the myocardial depressant factor, which does exactly what it says, myocardial depressant factor. So it means it enhances negative inotropic effects. Less stronger contraction, less stroke volume, less blood pressure. And then our third group that we're going to look at, or that can also be altered, is the afternote. So that will be what we, so this will be this group of us where a patient where something in the history is talking to us about their systemic vascular resistance. So those are mostly your patients that are vasodilated. So our biggest group of patients that we see most often here in Africa, South Africa, the whole of Africa, is septic shock. That is still the number one killer in most of our maternal patients, or is actually number two. Number one is postpartum hemorrhage. But in general, also sepsis is still, despite the whole drive, the sepsis campaign, everything, we still do have a lot of sepsis. Unfortunately, by the time the patient comes out, they're already in full-blown sepsis or septic shock within this multi-organ dysfunction aspects. But basically, if it's afterload related, it's all about vasodilation. So we see specific patients with pyrexia, obviously, will vasodilate, trying to excrete that excess heat or temperature from the body. Patients' CO2 increase can also contribute to vasodilation, but the biggest issue here is the release of mediators. So normally, those mediators are released, obviously with the onset of any invading organism, bacteria can obviously trigger that. And then also when there's tissue ischemia, it also triggers the release of mediators. There are many, I think there are about 36, but the ones that we focus on that we see most often here initially is your histamine, your bradykinin, your prostaglandins, because they are potent vasodilators. Can you see what happens now? The body is compensating up in a certain stage, trying to cause vasoconstriction, trying to get the blood pressure up to perfuse the brain, the heart, and the lungs. And as this tissue ischemia becomes worse and worse, there's more and more mediators that are released. At that stage is then when that vasodilative effects is going to overwhelm the little adrenaline that's still left. That's why we sometimes see whether you mix your adrenaline double strength or triple strength, later you don't see any effect in those patients because of this high levels of mediators that's causing vasodilation. So by that, the stage that the patient decompensates is when all these compensatory mechanisms are actually utilized, and now there's high levels of vasodilative mediators causing vasodilation overpowers that, and that's when the blood pressures drop to 30, 40, 50 systolically, and the patient goes into irreversible septic shock. All right. So what we're going to see then is that's what I told you right in the beginning, what we're going to look at. We're going to start on this side. So we're going to look at what will happen now. Now that the blood pressure is low, what are we going to see? I really like, I'm going to do it here. So now we go, if we look at the central nervous system, so what is the underlying problem now is that the patient's systolic blood pressure is less than 100. So as we said, your blood pressure regulates your cerebral perfusion pressure. So if the blood pressure is low, then the cerebral perfusion pressure is low. Remember, your cerebral perfusion pressure is exactly what it's saying is important. Then that's the pressure we need to give off oxygen to the brain. So what's going to happen if the blood pressure is low, the cerebral perfusion pressure is low, so then we get that state of cerebral ischemia. And then what will happen there, that we normally see cerebral ischemia then leads to an increase in the cerebral membrane permeability. And what will happen in the cerebrum is that there's going to be leakage of fluid into the surrounding tissue, and they do then develop some degree of cerebral edema. But also what we see very significant here, that we see when we assess the patient and you look at the level of consciousness or you assess using the Glasgow Coma scale, is that we see that typical signs of agitation, confusion, disorientation. Yeah? And I always tell the students also, when you look in the units, what do we normally see what happens there? Everybody runs for the restraints. Yeah? Or we run for the antivenom, we want to sedate the patient. But we have to ask ourselves, why is this patient combative? Why is this patient agitated? Why is the patient pulling on everything? Because underlying this patient, if the patient's blood pressure is low, they have some degree of cerebral ischemia. So it's already a sign of deterioration. We have to ask ourselves, why is this patient agitated? Why is this patient confused, disorientated, etc.? So this is what we have to ask, because this is already a sign that are missed, because we just treat the symptom and not the underlying problem. So we need to ask ourselves, why is this patient confused? And not, yes, we have to protect the patient, we have to keep the patient safe. So I do agree and I do understand we do sometimes have to restrain the patient. But the fact is we still have to ask ourselves why. Because there's already shown us that there's signs of cerebral ischemia. And why? Because of the low blood pressure. And that's why we have to ask ourselves, so is it a, because that comes into the comes in under the management, we're going to say, okay, so is this patient, is it a volume problem, is it a contractility problem, or is it an afterload problem? And now we're focusing on what's happening this side when the patient is deteriorating. Then also, if you go to the next system, so then also if we look at the respiratory system. So then again, we're going to see that if the patient's blood pressure is low, then it means there's not enough pressure to give off oxygen to the alveoli. And this is all related now to that peripheral perfusion pressure. So remember we said if there's not enough blood pressure, then the peripheral perfusion pressure is low, so that's the pressure we need to give off oxygen to the tissues, the muscles, and the cells. So what's going to happen now is that the alveoli, there's going to be ischemia of the alveoli. And if there's ischemia of the alveoli, you get increased capillary membrane permeability. So there's edema. Oh, I think it's like this, edema, doesn't matter. So there's edema or swelling of the alveoli. So that means now there's going to be a decrease in the surface for gaseous exchange. And what happens now? The patient becomes more and more hypoxic. So you see, it's a vicious circle. Because primarily the patient is deteriorating because of this underlying condition of volume contractility after they are developing some form of shock. But secondary now, it's also going to influence the level of oxygen because now the alveoli is going to become edematized. So what we normally see very typically, if there's swelling or edema. So can you see now when you auscultate the lungs, there's less air entry. When you look at the X-ray, and that's already the onset of or contributing to maybe later full-blown ARDS. But initially now, because of the swelling and edema, they now develop what we call a diffuse oxygenation problem, or they develop hypoxia. So it's much more difficult for that oxygen to diffuse through this big layer, to bind to the hemoglobin, to be given off to the tissues, the muscles, and the cells. So now already there's now another emerging problem because on the one side, primarily, there's not enough pressure to give off this oxygen. Secondly, now the patient becomes hypoxic, so there's also not enough oxygen to be given off. And that imbalance between oxygen demand and oxygen supply becomes more and more significant. So now already also, so we saw already firstly, there's cerebral involvement. Can you see there's respiratory involvement? So slowly but surely, what will we see when we do the arterial blood gas? Yeah, specifically, there's going to be a key aspect to look at is to see what is the patient's shunt. So we know the normal shunt is 2 to 5%, and that represents the non-functional area of surface in the alveoli. So the more edema there is, the less surface there is for gaseous exchange. What's going to happen? The shunt and the ANGPO2 is going to increase. So that represents a larger non-functional surface for gaseous exchange, which means what? It means that now the PO2 is going to become less and less, and the patient's also now secondary going to become hypoxic, primarily hypotensive. Are you still with me? Happiness? Yes.
Crashing patient.
Sorry?
It's a crashing patient.
Yes, yes. But can you see why we say we have to pick up on those small things? Because already, even if because remember, initially this patient can still have an acceptable PO2 level. But when you look at the blood tests, what are you going to see? The shunt and the AADPO starting to increase. So initially they might still have a PO2 of 70 plus. But already the fact that there's an increase in the AADPO2, there's an increase in the shunt, is telling us that something is going on. And slowly but surely, it's like, you know, when you sprain your ankle, you have looked up, no, it wasn't that bad. But half an hour later, you can see there's some edema. And this is exactly what's happening in the alveoli. Gradually, there's going to be some more and more fluid leaking in, more edema, less and less surface for gaseous exchange. So gradually, literally hour by hour, this patient's going to deteriorate and is going to become more and more significant. Then also, so this is respiratory. So then also when we look at the cardiovascular system, we're also going to see some challenges there. So obviously again, the main problem here is that the blood pressure is low, so the peripheral perfusion pressure is low, so we know there's not enough oxygen to be given off to the cardiac muscle. So this patient now develops what we call myocardial ischemia. And already, as we said, remember, underlying there's already now the release of the stimulation of beta-1 receptors, so the patient starts becoming tachycardia, which means now they need more oxygen, and the ischemia becomes more significant. So what's going to happen here? Normally there's two main impacts that we see here. So myocardial ischemia is also going to contribute to that negative inotropic effect. As we said, that will then lead to less contractility of the heart muscle, and then also obviously a decrease in the cardiac output, and that will further contribute to a decrease in the blood pressure, so it becomes even more compromised. And also on the other side, if there's myocardial ischemia, we also know that can increase the risk for dysrhythmias. So they're now starting to develop any type of dysrhythmia. Sometimes they might get VEs, later they can develop VTAC, and ultimately they go into ventricular fibrillation. They can have AF, they can have any type of dysrhythmia because of this myocardial ischemia. So also that is then going to influence. But then what we also see now, at this stage already, there's going to be some degree of tissue ischemia with a change from aerobic to anaerobic metabolism and the formation of lactic acid, which leads to metabolic acidosis, which now also contributes here, because also now there's going to be hydrogen ions in circulation. That's also going to further cause negative inotropic effects. That hydrogen ions can also contribute to cause myocardial irritability and risk for dysrhythmias. And this, I don't know why he's got dysrhythmias, he's not a cardiac patient. But remember, that's also sort of the assumption we have, is if you have dysrhythmias, you must be a cardiac patient. But it's not. This patient can have dysrhythmias because of this, primarily the myocardial ischemia. Can you see now? The myocardial ischemia is primarily due to the fact that the patient is hypotensive. But also remember, secondary along the line, the patient becomes more and more hypoxic. And this also now contributes to enhancing or aggravating that myocardial ischemia. And now also, can you remember we already said there's going to be some degree of the release of MDF or myocardial depressant factor, which further contributes to negative inotropic effects. And that's why we see gradually this patient just deteriorates more and more because it's really a vicious circle. And that's why we really have to think this is what's going to happen if we miss those signs of deterioration. So that's also why we have to look as we said initially, you might see still a normotensive blood pressure, but with a slight tachycardia. But when you look at your blood pressure, you already see that your diastolic pressure is high in relation to your systolic pressure, which also showing you already that there is some signs of or they're trying to compensate, and that is the sort of those signs that we have to pick up. That's also why it's important for us to look at the patient's lactate level. Because on the blood test, the lactate, so we normally say 0 to 2 millimoles per liter, but we always aim, we want it actually as close as possible to 0. Because lactate actually implies to us what is the patient's tissue perfusion. If there's optimal tissue perfusion with enough oxygen, there's no anaerobic metabolism, there won't be lactate. So the more lactate there is, the higher the lactate, the worse the outcome for the patient, because lactate tells us that there's impaired tissue perfusion. And there's two main reasons, either hypotension or hypoxia or both. Those are the two biggest contributors to this lactate. So the higher the lactate, the worse this anaerobic state in which all the systems is actually, and there's extensive tissue ischemia with this high levels of lactate. And also the other very bad thing about lactate and the metabolic acidosis is this circulating hydrogen ions. This hydrogen ions also impacts negatively on the level of consciousness. Because now there's cerebral ischemia, but if there's now also circulating hydrogen ions, they cross the blood-brain barrier. And they cause, I won't try to write that, they cause encephalopathy, okay? Which actually means cerebral intoxication. So what those toxins do, they basically decrease the rate of neuron transmission. So now the neuron transmission becomes slower and slower, and what do we see? We see that this level of consciousness becomes more and more compromised because of this hydrogen ions that crosses the blood-brain barrier. So they actually cause cerebral intoxication.
So how often, I'm curious if it's the same here as elsewhere, when a blood pressure drops on the floor, the nurse calls the doctor and usually a fluid bolus is given without necessarily the investigation of what is causing. Does that occur? Yeah. Okay.
And that's the same thing
Same
I'm trying
all
to.
over.
Yes. You see, that's also even when I teach the basic students, I try to get that out of them because that's typical. We usually say if the blood pressure is low, run for the ringers. Yeah. They all want to give a bolus, but we first have, and that's why it comes in with history and assessment. Because if it's a preload problem, yes, go for it, give the bolus. If it's an afterload problem, yes. But if it's a true contractility problem like your cardiogenic patient or your patient in cardiogenic shock, that is you never give a bolus. Because they might even already have pulmonary congestion, pulmonary edema, because of the fact that they have a severe contractility problem. But that is typically what we see. People think that sort of equals to a bolus, and it's not always. But can you see now also because of this anaerobic metabolism, lactic acidosis, now secondary, it also alters even the level of consciousness even more. So already the central nervous system is impaired, the respiratory system, the cardiovascular system, and now we're going to look at the gastrointestinal system. And the poor old gastrointestinal system, I always say, is like the, we can divide it into three components here. Because what do we see? So if that, your catecholamines, your adrenaline and noradrenaline is released, the body, yes, will try and shunt the blood to the heart, the brain, and the lungs. But it's not to say it's going to meet that oxygen demand versus the oxygen supply. But obviously the gut and the renal system is on the lowest end. So they're going to get the least oxygen because, first of all, what's going to happen if there's that vasoconstriction, you get splanchnic vasoconstriction. So the gut, the perfusion to the gut is actually impaired to a very, very low level because it's trying to shunt the blood to the heart, the brain, and the lungs. So already there's going to be gastric ischemia primarily when the patient is in shock due to splanchnic vasoconstriction. And that splanchnic vasoconstriction is going to be because of this release of the high levels of adrenaline and noradrenaline, because of that alpha stimulation that's going to cause vasoconstriction. So this is sort of your normal compensatory pathway trying to increase the blood pressure. But what happens intragastrically now is if we look at these three important components. So it's the gastrointestinal, the intestines. Another big component is the liver and the pancreas, which is part of the gastrointestinal tract that will also now be compromised. So obviously now there's going to be gastric ischemia, primarily because there's splanchnic vasoconstriction, but also now again because if the blood pressure is low, then the peripheral perfusion pressure is low. Now the patient's going to develop gastric ischemia. And obviously, the lower the blood pressure, the more severe the gastric ischemia. And what happens if there's gastric ischemia? Then there's going to be typically those patients that we all have, they develop paralytic ileus because of this accumulation of fluid intragastric. So now if we insert a nasogastric tube, then we see they drain all that volume. We see that green stasis fluid. But what do they also lose with that volume? They also lose now electrolytes. So specifically there, your electrolyte, your potassium, your magnesium, and your phosphate is also going to decrease. And that already we know is now going to increase the risk for arrhythmias. And further, what's going to happen is going to decrease the cardiac output even more. Blood pressure is going to go even lower. And also now, because of this fluid, now also your circulatory volume becomes less, further impacting on the blood pressure. So ultimately, you can have a patient with yes, primarily, then it might be a preload problem. But secondly, because of hypoxia and ischemia, there's also some contractility issues in terms of negative inotropic effects. And now you see also that if the gastrointestinal tract is always about fluid and electrolytes, so that's why we have to supplement those fluids. So even and initially, what will we see here when there's gastric ischemia? There's going to be a decrease in bowel sounds. Oh, and that is the other thing I have struggled with the students. Because I think you just go, there's no bowel sounds. Yeah. So after 10 seconds, they determine there's no bowel sound. So we actually say, if that is the navel, that's your 4 quadrants. You should at least auscultate 1 to 2 minutes per quadrant before you can say there's no bowel sounds. Not because, no, there's nothing. Yeah. All right, so we also have to make sure, but that's obviously already a sign that we miss, because why isn't the bowel sound? Because underlying the patient is compensating. We starting, because first there's this phase of compensation, and then we must sort of pick up those signs of deterioration before the patient goes into full-blown shock. Then the liver is also going to be impaired. So again, if the blood pressure is low, the peripheral perfusion pressure is low, so there's not enough oxygen to be given off to the liver, so they develop what we call hepatic ischemia. And one of the big problems here is that now, because of that, there's going to be less production of vitamin K. And what's happening now? Now the patient is in increased risk for bleeding. And ultimately, what we see is that as the sort of the worst case scenario in multi-organ dysfunction, they go into a state of DIC. And that is one of the contributing factors. But this is a big problem. They can now have a risk for bleeding because even the liver function or the functioning of the liver is impaired. And the other issue here is the pancreas. The same there, there's not enough pressure to give off oxygen to the pancreas. The patient goes into a state of pancreatic ischemia. And there we see two things. Primarily, there's going to be more release of MGF, or myocardial factor, which is the enzyme that's released by the pancreas when the pancreas becomes ischemic. And is this pancreas going to be ischemic? Yes, because splanchnic vasoconstriction means there's hyperperfusion of the pancreas. Secondly, there's not enough pressure to give off oxygen. And thirdly, already at this stage, there's some degree of hypoxia, which means there will be less and less available oxygen to be given off. So NDF is going to contribute to a negative inotropic effect. So it means there will be less stroke volume, therefore decreased cardiac output, and further negative impact on the blood pressure. And also, because of this irritability, but primarily, the NDF will have that negative inotropic effect on the body systems. And then also we know if there's pancreatic ischemia, there's going to be less production of insulin, and then we normally see that the patients will start developing an increase in the blood glucose, and that again can lead to metabolic acidosis, and then again more and more hydrogen ions in circulation, which will cross the blood-brain barrier, alter the level of consciousness, even more myocardial irritability, risk for dysrhythmias. Now sometimes we have to give the patient some form of insulin, like Actrapid or Novorapid, whatever you use. Also remember, insulin needs a carrier to go over the cell membrane, and the carrier is potassium. So now that can also have a negative impact on your electrolyte levels, which can again contribute to dysrhythmias and really making the patient, or contributing also to further hemodynamic instability. All right. So this is what's going to happen also. So again, can you see just actually very simple things like assessing for bowel sounds, assessing your electrolytes, and so, but it's not a cardiac patient. Even looking at the glucose, that I'm trying to get out of this. No, sister, she's not it's not a diabetic patient. So I said, okay, so you only look at the glucose of diabetic patients, because that's sort of the connection they have. Or we don't look at electrolytes because it's not a cardiac patient. No. We've seen now this patient, irrespective, they have the risk to become or to have those electrolyte imbalances that can then lead to dysrhythmias, hemodynamic instability. So also these patients, yes, we also have to have that as a baseline to see what is the patient's glucose level, because this can already also show physiological stress. And then the second last system we're going to look at is the renal system. And also, as we said, the kidneys will also be already compromised because there's going to be renal vasoconstriction as part of the compensatory mechanism because of the release of adrenaline and noradrenaline. So trying then to shunt the blood to the vital organs. But normally, two things happen. So on the one side, remember right in the beginning we said that blood pressure oil also regulates the renal perfusion pressure. So what happens here is the same. If the blood pressure is low or there's a decrease in the blood pressure, there's a decrease in the renal perfusion pressure, which means the glomerular filtration rate will be decreased and there will be a decrease in urine output. Now also remember, what happens if there's decreased urine output or the output is less than half to 1 mol per kg per hour? You get accumulation of your toxins in your waste products. So that again can now cause some issues because usually also now you can see an increase in sometimes the potassium, but also an increase in hydrogen ions. And where will those hydrogen ions go? They cross the blood-brain barrier, they cause cardiac irritability. So it's just downhill from the start if we don't reverse that. That's why we need to look at those signs and symptoms. Also, so that is related to the renal perfusion pressure. On the other side also we know that if the peripheral perfusion pressure is low, there's also going to be renal ischemia. And then ultimately there's going to be necrosis of the tubular part of the nephron, and they then ultimately develop acute kidney injury. So primarily, yes, it's because of this hypotension that the patient has. It can also be because of the hypoxia. And also now remember, other very big thing that plays a role here is toxins. Because we also must think now, let's say for instance, this is a patient with some, let's already we suspect septic shock. So there's some invading bacteria, organism, virus that are multiplying. Most of those gram-positive, gram-negative bacteria either release toxins when they are still alive in the system or when they are distracted by your normal immune response or by the antibiotics. And what do those toxins do? Those toxins damages the endothelial layer, the tubular part of the nephron. Those toxins also injure the endothelial layer of the alveoli, contributing to that diffuse oxygenation problem and the onset of ARDS. Further contributing here to acute kidney injury. Now, what do we know sometimes with these toxins? That patient needs to get some for antibiotics, and they are also now exposed to nephrotoxins, like your anti-inflammatories, your antibiotics, your antifungal, and you see. So it's really and some of the antibiotics, which they need, yes. And that's why again now we have to also practice that antibiotic stewardship. So how do we give these antibiotics? What is the level of the urea and creatinine? So we know now, previously we always just said you give the antibiotics in a piggy bag over 20 minutes, but we realized that the peak levels is very, very high. And then it's your nephrotoxic effect on that. Because remember now, what do we have here? We have a poorly perfused acidotic kidney. And on top of that, we're giving the patient a nephrotoxic drug. So that's why they actually just have or go into acute renal failure. So that's why it's important if we really practice those principles of antibiotic stewardship. So yes, we still give the same dosage, but now we give it over 8 hours. So now we see sort of that effect. We don't have that we used to have every 8 hours. We give that. Now we give the medication over 8 hours, so we try to stabilize the plasma level better, that we don't have that peak and then that more severe nephrotoxic effect on this already poorly perfused acidotic kidney. And then the last group we're just going to look at is then whatever stays over now, we put under the umbrella of tissues. So all the other muscle tissue cells is then also going to be deprived of oxygen. So all the other peripheral tissues, muscle cells, because we know now the blood pressure is low, the peripheral diffusion pressure is low, so there's going to be plus tissue ischemia. And what happens if there's tissue ischemia? There's the change from aerobic metabolism to anaerobic metabolism. And that then leads to the formation of lactic acids. Metabolic acidosis plus. And more hydrogen ions, and it's just a vicious circle.
So the question, and this is to the group, there's a lot of data coming out now about the gut microbiome being messed up when all of this happens, and weak endotoxin.
Yes.
Which then, so it's not, so the gram-negative bacteria is not only coming from initiating the outside, it's part of your own. So are any of your places doing hemoperfusion with polymyxin B to get rid of endotoxin? Because I know it's being done in Europe, in Japan. They're looking at it in the United States. They're doing some studies now, so I was curious. No. It's usually run off the hemodialysis or the CRRT machine with a special cartridge. So it's not, yeah, okay.
Well, so that is a very important thing, because what happens now, and that is actually where that leak comes from. So now you've got this ischemic, this plus ischemic gut. And actually what happens now is that because of this ischemia, now remember it's ischemia because of already there's going to be spastic vasoconstriction, which means there's going to be hyperperfusion of the gut. There's hypertension, there's hypoxia. And all of this is contributing, it's actually plus. So it's like triple insult on the gut. So basically what happens, if you look at that inner lining of the gut, you've got all the belly, I can't draw very nicely, but you've got all that, and even in the belly in the gut, there's a there's an endothelial layer around it. So that even that endothelium needs oxygen, nutrients, glucose for optimal metabolism. So basically what happens, you get ischemia of this endothelium layer. And then because of what happens after some time with ischemic tissue, they say it depends by about 2 to 4 hours, you get micronecrosis. And remember, micronecrosis, we always say, if you actually look at that micronecrotic tissue under a microscope, it's like wet toilet paper. When you wet toilet paper and you touch it, it just disintegrates. And what actually happens is there will be micronecrosis everywhere in the gut. And it's almost like you take a toothpick and you prick small holes in the gut. Because what's going to happen now? Now you get that translocation of bacteria out of that micronecrotic areas, and it leaks out into the peritoneal cavity, and that is where from that toxins that's normally, or the normal flora of the gut, is toxic to the rest of the system. And now you get that translocation of bacteria that really just makes the whole situation worse and worse and worse. So, if we then just come back there, so we spoke about the acute respiratory, so you can see from a healthy alveoli how everything starts changing and you get less and less surface for gaseous exchange, more and more hypoxia. So already we spoke about the first three, and you see, so it started off primarily due to hypertension, that's the problem. And then a secondary, the patient became hypoxic, and if there's any reason that the patient is also not having this optimal HB, it's another insult. We spoke about the toxins, so these toxins also damages the endothelial layer of the alveoli, also contributing ultimately to the patient developing ARDS. And then obviously what sometimes happens, we need to increase the oxygen level. So remember, if you give more than 50% oxygen for more than 24 hours, we're also exposing our patient to oxygen toxicity. So basically what happens here, the oxygen that's not utilized will be metabolized. And it's metabolized to oxygen-free radicals, which is a toxin. What do toxins do? They damage the endothelial layer, causing more capillary leakage, causing more edema, causing less and less surface for gaseous exchange. The patient becomes more and more hypoxic. And also, if we give higher levels of oxygen, we wash out nitrogen, so that also contributes to atelectasis, less surface for gaseous exchange, more and more hypoxia. And if maybe from the history your patient had massive blood transfusion, so normally we say any 6 units and more of blood and blood products can contribute also to massive blood transfusion complications. So that's also why we need to practice that principles, that we say we don't stand there and inject blood with the syringe or cause that severe pressure on the back, because we break the red blood cells, or there's hemolysis of red blood cells, and that actually acts as microemboli. So what's going to happen now in the intravascular, there's going to be microemboli circulation. So it's micro, so it goes through, but where will it then occlude? Your microcapillary circulation in the brain, in the alveoli, in the gut, in the liver, in the pancreas, in the kidneys. So that was micro-occlusion. So specifically when you look at ARDS, it's going to then occlude the microcapillaries in the alveoli, then causing decreased oxygen supply to the alveoli, more ischemia, more swelling, less surface for gaseous exchange, more hypoxia. So it's really a vicious circle. Oops, we lost it on the wrong side. So just to recap, other things that we can also consider is to also make sure that we prevent aspiration, whether it's micro or macro aspiration. So we all have that, we all use the VAPS bundles where we elevate the patient's head. We usually give them proton pump inhibitors to try and neutralize the pH to be less acidic. So if there's some degree of micro aspiration, the insult to the alveoli is less. From the history, maybe any trauma, fat embolism, all of that can influence, but ultimately it's about damaging the endothelium, contributing to edema, swelling, less surface for gaseous exchange, more and more hypoxia. And then, as we said, the decreased level of consciousness is also very significant, primarily because of the cerebral perfusion pressure that will be less, and then that cerebral ischemia becomes more and more significant with the toxins and crossing the blood-brain barrier, hydrogen ions. Also, we'll see later as the patient's renal function deteriorates, the urea and creatinine starts to elevate. And urea is also one of the metabolic toxins that crosses the blood-brain barrier and can contribute to the cerebral intoxication. And also, we need to always make sure that we monitor the patient's blood glucose, because if they're hypoglycemic, it also has a direct impact on the level of consciousness. And then, as we said, sort of as a last resort, when we look at actually multi-organ dysfunction, those patients can also then ultimately develop DIC because of this damage to the vascular endothelial layer. So basically what happens with those patients, or if you look at the DIC just a little bit, we have a few minutes time. Basically what happens there is ultimately if you look at the vascular bed, we've got the tunica intima, which is the inner lining of the vascular bed. Again, it's like a mucous membrane. It also needs oxygen, nutrients, glucose to have optimal metabolism. So what happens now, either because of this ischemic, so those phase 3 gives or causes ischemic injury to the tunica intima, or to that endothelial layer. So if there's ischemic injury, the same principle, because of the ischemia, there's going to be microcapillary hemorrhage, and when the patient starts having this microcapillary hemorrhage, what will the body do if it sees hemorrhage? It will then activate your clotting factors, and will start forming all this microemboli throughout the vascular bed. Also, if you look in terms of hydrogen ions and toxins, they usually cause acidic injury to the endothelial layer, which means also the same. Due to the acids, there will be damage to the capillaries that will start bleeding, and what will the body do? It will start forming microemboli. Then at a certain stage, the body realizes that there's multiple microemboli, and then it starts to produce or overproduce clotting of So first of all, you're going to use your platelets and clotting factors here to form those microemboli, and then the body will see this production, and it will start producing blood to try and dissolve these microemboli, and then that will lead to bleeding, plus. Now when the patient starts bleeding, they already have there's a decrease in your platelets, and there's a decrease in your clotting factors, because initially the body used it to form those microemboli. And that's why the patient then starts bleeding. It's actually as if they're getting an overdose of the anticoagulants. So the body will produce plus anticoagulants. And then you see the more microemboli, the more anticoagulants, the more bleeding. And that's why they can be in a state of DIC where there's just no clotting, and they bleed from everywhere. And it's irreversible. Because there's 3 components to it. And you see there's ischemic injury, there's acidic injury, and then there can even be some microemboli that is now in circulation, and you see from that massive blood transfusion. So the more microemboli the body recognizes, the more anticoagulants will be produced, the more bleeding, the less platelets, the less clotting factors. And that's why they then basically neutralize. Right. So all of those contribute, so we have to make sure. And then, ultimately, can you see, if we look at the hemodynamic patient or the patient, the deteriorating patient, on the end of this. So what's going to happen this side is ultimately, as I've discussed here in the morning, all of that comes down to the fact that there's less cerebral perfusion pressure, renal perfusion, and peripheral perfusion pressure. That then influences all the systems. And ultimately, sadly, by the time we admit the patients from wherever they come, most of them are already in multi-organ dysfunction because they're already definitely hemodynamically unstable. Most of them already show signs of a decreased level of consciousness. Some degree, not necessarily already have ARDS, but already having some form of a diffuse oxygenation problem, increased AID PO2, increased shunt, and a lower PO2 level. They already can have some degree of either decreased urinary output already, or if the urea and creatinine is elevated, they already have some form of kidney injury, and ultimately they develop DRC. And those are usually those patients we are not able to revive, sadly, because by this stage all their compensatory mechanisms is exhausted, and they don't have any reserves to fall back. And that's why we say we have to ask ourselves, why is the blood pressure low? So ultimately it comes to the management, but that's another day's workshop, is to look at the different types of shock, and that will guide us to then make sure that we manage the patient who needs fluid, yes, but the patients who maybe also need positive inotropic support, patient that needs intra-aortic balloon pump, whatever they need. But for us to remember, we have to maintain the blood pressure so that we can maintain cerebral, renal, and peripheral perfusion, so that at the end we can prevent this from happening. And that's why we start with the history, we do a comprehensive assessment, and we already identify those signs of deterioration. Even as I said initially, they won't have ARDS, but they're going to have a diffuse oxygenation problem. So what will we see? Yes, they might still be able to maintain a 70 or 80 PO2, but already we see they need 40% oxygen to do that. We can already see there's an increase in the AID PO2, increase in the shunt. So we are seeing they are moving towards that, and that's why we need to be able to identify why the blood pressure is low, so that we can manage that, so that we can try and reverse all these complications and all these things that ultimately happens. And that's why the outcome for these patients are actually not good, because already, even if it starts primarily with hypotension, along the line they become hypoxic, and they've got all these toxins in circulation, and they're actually in this state of ischemic and aerobic state. Right. And I think that is it. So I think we have a few minutes. So also what I can, for those of you who are in clinical practice, and they are concur with what Catherine also said this morning about, in service and training and education. So I was, for many years, I was a unit manager of the thoracic ICU. That's my passion. I love thoracics. And also what we did, you sometimes see that, yes, the organization put some things in place. But for us, it didn't work to have people, that must now go out of the unit for 2 hours for in-service training, because we didn't have enough staff. So what we did, we started some things where we looked at what will work in our unit. So we realized, to say now we're going to have a 2-hour session, it's not going to work here. So we just started twice a week, Tuesdays and Thursdays. Again, we decided what will be the best time in our unit. And we said, okay, 11 o'clock, because then the rounds are done, and we've done the basic nursing care, and it's before visiting time. And then we had smaller, just 30 minutes. And we also rotated. And said, okay, I'm not going to do every week, so who's going to teach us something this week? And you know what, sometimes we also did things about culture. Because remember, we've got 11 languages, 11 cultures. Yeah? So it was also interesting even learning that type of things. Maybe sometimes it was something related to ethics, something related to patient care, something related to self-care. But they use, no, that's not good. No, we must acknowledge that will be interesting, let us hear. And you also give that people or your staff members an opportunity, they feel okay, they've been acknowledged, so we can all learn from each other. They also learn other skills, now you must present in front of your colleagues, you also learn other skills. I think that was really good, we learned a lot. And then you see that all those small things are valuing, appreciated. And that's because I come from an appreciative background, I do a lot of appreciative inquiry work, so we say that in every person, organization, anything, there's always something good, but we can always make it better, but we ultimately strive for excellence. So there's always those three things. And there's always something good. We can make it better, but ultimately we always strive towards excellence. So after 35 years now, I'm still striving for excellence, but we are getting there. But make those small changes. Like I told you this morning, we changed one thing that year, and there was so many other things that have changed. Because it's all about, and that's also linked to person-centeredness. So a lot of my work is also about creating a person-centered workplace culture. Because we moved away from family-centered, student-centered, because we are all a person. And even just greeting, we started, I said to them once, because just that person-centeredness is about we are all a person, whether I'm the unit manager, whether you are the security, whether you cleaning staff, whether you all have an important role. And just that small things about saying, sure, Mama, your bathroom looks so nice, it smells so nice, it's so nice to come here. You can just see the way they walk because they've been acknowledged, even if they are on a different level. We are all people, we are all persons, we've got the same basic things of appreciation, of acknowledgement, of getting some positive feedback. And that's what we focus on. So even when we looked at those audits of the drug books in that specific unit, I think they got 36%. But we didn't focus on that. The next month, when they audit, we see they were on 46. So what did we do? We appreciated. So we put other things like, well done guys, you have improved with 17%. Well done, with stars and balloons. We didn't say, oh, it's only 47. Because they started, and within about 3 months, they were at 89, 99%. Without us focusing on that, it is the way that you appreciate, the way that you focus on the positive things. Or you just ask them, what will, because that's part of appreciation. So you focus on what is working well, what are the good things, and you ask them, you never talk about mistakes or challenges or things like that. You ask them, what are your wishes for this unit? If you ask family members, what do you say? Oh, sister, I wish I can stay with my mother for a while. I wish there wasn't visiting time or visiting hours because I don't have transport. I wish for this, I wish for this. And you see, those are the things that want more of. And those are the things that we must listen to. So we had one hospital unit, I had a master's student. So I said to her, okay, let us take up that challenge. So we challenged them to open the visiting time. Oh, I know. It was like, I don't know, we're going to bring some virus in there or anything. But at the end, the unit manager said she worked with us. She said, okay, she's willing to do this. But, the infection control system was like on us because it's never going to work. Everybody's going to, I said to her, no. We will work according to the same principles is going to come. If we see that the infection rates increase this and this, then we stop it. And you know what? That unit is still, 6 years later, still an openly visiting unit. They've got the lowest VAP. They've got the best patient feedback. They've got the lowest of all the infections. Because now we know, and even if you tell the family, you can, but remember, we still apply the same principles. They have to wash their hands, they have to mask, they have to be there below the elbows. The same principles come. So we proved them wrong, but it was like that thing, if it's never worked, it's not going to work. And we said, but let us challenge that. So in one unit we started that. And then that's what we observed. We looked at things like infection rates, we looked at different things. And it didn't change, it actually improved. Because they saw the feedback, they saw the value of the family members, the patients, how they value. No, people will say, no, you can't come here. No, that's our job. We must do this. But who's saying that? Sometimes all that family member wants to do is just maybe to rub the feet or, to comb their hair. You see. And then I asked them, but why can't they do it? No, they're going to pull out the lines. I said, but they're working here on the hill. We are going to be here. So, that type of thing. So it was really a culture change. It was a change of the way we do things. And that is actually what workplace culture say. It is the way we do things here. And we decided we're going to do it in a different way. But again, it was our decision. It was a group. Everybody worked together. And those negatoids, they said, no, never going to work. They all changed, And even that greeting, one or two of actually quite a few of the staff members actually came to me afterwards, and they said to me, what, when we started this, I thought it's never going to work. Because people are racist, people are this, people are, and what I've realized is I was actually the one that was racist. Somebody to say that to you.
It's pretty powerful.
That's how to realize how much they have changed, because now they've seen that whoever it is, if you greet, if you smile, irrespective if it is a language barrier, people understand that. That thing of just saying, it's alright, or just, they understand that, irrespective. And the way that they saw how many things changed, how nice the environment became, how supportive it became, because we just changed one small thing. So even with this type of training and thing, just change one small thing. Give anybody that wants to. Sometimes even if we just share something, and then we know, okay, your child is ill or she has this problem, we can support. And you learn something that you can change yourself and you can change around you, but at the end it's a personal win. It's also a win for patient safety, for patient outcomes, for workplace culture. Then it's nice to go to work. You feel supportive, you feel, that today you can make a difference. All right. Thank you very much.